Yes, you are.
Okay.
Yeah. Yes.
Hi. Good morning, everyone. Today I'm going to discuss about traumatic brain injury. So before I jump into the topic, let us acknowledge all the women in our lives in Cloud Physician, all our partner hospitals. A very happy Women's Day. This particular year is all about celebrating equity. So I think it's really important that we acknowledge that, and definitely everybody should understand equality is not equal to equity. So let us be mindful of that and wish all the women. Thank you, Shashi, for choosing this topic in March, because March also happens to be the Brain Injury Awareness Month. Let's dive into the topic. A 40-year-old gentleman was found unconscious after a possible hit and run road traffic accident. He was brought to the emergency department, and examination revealed a GCS of just one second. Yeah, with a GCS of 6. His pupils were 4 mm in size, bilaterally equal and fixed. He had CSF autoria on the left side. On examination, his heart rate was 42 beats per minute, regular, and blood pressure was 168 bar 108 millimeter of mercury. Primary survey also revealed fracture of the right third to ninth ribs with evidence of hemothorax, pneumothorax, or hemoperitoneum. A CT scan of the head showed subarachnoid hemorrhage with left temporal subdural hemorrhage, a left temporal and parietal hematoma, with mass effect causing an 8 mm shift of midline. So let us dissect this particular scenario. I'll come back to this in a little more detail and discuss all the management. This is something which we come across every day. Like, we've treated hundreds, tens, and hundreds of patients of these. So let me just give you the outline of my topic today. So I'm going to discuss in detail this case scenario. What is the problem statement of traumatic brain injury, the definition and the classification of TBI, pathophysiology, the scoring systems, a short note on the intracranial pressure and how do we monitor, how do we manage all those things, and the advanced methods of neuromonitoring, management of TBI and its complications. I'm going to touch very briefly on the management, only the controversial topics, and how do we prognosticate the TBI, and finally the prevention. So let's dive in. So, like I discussed, this is a 40-year-old gentleman, unconscious, possible road traffic accident, brought with GCS of 6/15. Pupils were 4 bilaterally equal and fixed. CSF autoria is there, and his heart rate is around 42 with BP of 168 over 108, with probably some rib fractures. All right. So, what are we going to do in this patient? Now, the question is, do we intubate or not? Right? So this is a common question. So first, as I'm going through the case, I'm also going to give you the guidelines of when you should intubate, when you should do CT, when you should do a particular intervention. So now the scenario we've reached is, should we intubate or not? So there are a few indications for intubation, and what are the factors we are going to consider before intubation. One, GCS less than 9, a peripheral capillary saturation of less than 92% despite giving the oxygen supplementation, the signs of cerebral herniation, the signs of aspiration, or a compromised airway. These are all the few factors which we consider before intubating the patient. Any of these are there, go ahead and intubate the patient. And what's the best technique to use while intubating the patient? That would be cervical spine stabilization with a technique of manual rapid sequence intubation with manual inline stabilization is the recommended technique. Because why this technique is adopted is, it reduces the sympathetic response, the agitation, and probably transiently increases the ICP and the cervical spine injury. It it takes care, it accounts into all these things. That's why this technique is better. So once we intubate the patient, the idea is to achieve normocapnia and no longer the hypercapnia or the hypocapnia like we've believed is beneficial anymore. The normocapnia is between 35 to 40. The therapeutic hyperventilation, if you're considering PCO2 around 30, it's only reserved for a very short period when there is sudden acute neurological deterioration like cerebral herniation or sudden rise in ICP, which is refractory to management. All right. And also the maintaining the adequate saturation of 90% and above with a PaO2 of more than 60 millimeter of mercury. to adequate oxygenation in the cerebral tissues. This is very, very important. And the sustained hypoxia, that is less than PaO2 of 60 and hypotension, should be promptly treated. And any hypotension with a systolic BP less than 100 should be promptly treated with isotonic fluids, normal saline, and blood products, depending on if the patient is bleeding from anywhere. And the needless to say, the vasopressors requirement while we procure the inotropes. And there is a small difference in the depending on the age group, the SBP targets. I'm not going to touch about it. It's a very narrow margin, but it is important to keep in mind. The other thing we need to do in our survey is doing the EFAST, ruling out all the other systemic injuries. We've already ruled out the hemothorax, pneumothorax, the cardiac tamponade, tension pneumothorax. All these needs to be thoroughly examined and addressed before we go forward. All this while securing the peripheral to wide bore cannulas, sending the samples, ABG, sending the cross match, blood products, all this. We are treating about this very sick patient right here. So I'm going to discuss briefly in mild and moderate in a little bit, but this is about the management of this particular patient. So once we did whatever is necessary initially, then subsequently will be our neurological assessments. Perform your progressively again GCS, pupillary monitoring, limb movements as the time progresses. And also, it's important to keep in mind the neurosurgical whenever patient is deteriorating, to involve the neurosurgeon as early as possible. And when we are sending the blood samples, the complete blood counts, blood glucose is very important to check, the serum electrolytes, coagulation profile, blood alcohol levels, urine tox screen. These are all mandatory. But we do understand the constraints in some of our hospitals where we do not have all the facilities, but at least the essential ones we have to send, whichever are possible. So the next comes to, once we intubate the patient, secure the airway, make sure the inotropes are in place, fluids are rushing, blood products are given, blood samples are drawn, all the involved parties are counseled, and neurosurgeon is informed. Next, we rush to the CT. So all this happened probably in a few minutes. So which all patients do I have to CT, if that is the question? So there are specific indications when we should consider CT. One of it is any patient with traumatic brain injury and GCS less than 15 should get a CT. Presence of vomiting as a symptom and presented with seizures is a suspicion of skull fracture. Age more than 65 years or less than 2 years old. Any history of intoxication or remotely sense there is some intoxication. There's amnesia before the event, and there's probable anticoagulant use for any of the systemic disorders. So these are the few indications, or probably the exact indications of doing a CT in an emergency room. Yeah. So what is the problem statement of TBI? So there are close to 346 patients out of 1 lakh who present with, this is the 2019 stats, worldwide representation, and close to 90% of them are mild TBI. Remaining 10% will account for the moderate and severe TBI. There are almost 8.5 million DALYs, that is disability adjusted life years, and almost 50 to 60 million people suffer from traumatic brain injury every year. Coming to the high income countries and the low income countries, high income countries, the common cause is the falls, and the low income and middle income would be the road traffic accidents. So these other things, apart from the green color label of trauma, all other things account for around less than what we've noticed. I mean, in the previous slide. So predominantly what we have seen, these falls and road traffic accidents, right? That 1% in the low economic and 12% in the other are all the other causes. So the definition of TBI, according to the assessment, this interagency which has come up into 2010, is TBI is any alteration in brain function or other evidence of brain pathology. Need to remember what the other evidence of brain pathology is, caused by an external force. So there are some confounding factors like intoxication and medical illness, but definitely a clinician judgment should be used to decide if it is TBI or the other confounding factors. When we say the evidence of brain pathology, it can be over a period of time as well, like a delayed or absent in a little while. So basically that we've figured out based on the clinical picture, the imaging and the lab results. So how do you classify TBI? There are many ways to classify TBI based on the etiology, the severity, location of the injury, the mechanism of the injury, and physiological response to the injury. So it can be a blunt injury, penetrating injury, blast related, and the commonly one which we use is based on GCS, the mild, moderate, and severe TBI. That is based on our GCS, but there are so many other available scorings. I will come to it shortly. But yeah, commonly used one is the based on GCS because it's the ease of use in the clinical practice. The Mayo classification, it considers the clinical and CT findings, so it classifies like definite, probable, and possible TBI, and also based on the location involved, it can be a diffuse or focal. Usually, in clinical picture, it coexists. It's very difficult to say it is only diffuse or it is only focal. So, depending on which part of brain is involved, a patient can present with those particular symptoms. Can be visual disturbances, can be neurovascular deficits, can be comprehension abilities, slurring of speech, vertigo. So basically the idea is depending on which lobe is involved. So if the patient in mild, some of the patients will be able to give history, or some of the attenders will be able to tell this is how he presented initially and then progressively deteriorated. So history is also important in a patient with a traumatic brain injury, and the progression definitely. If it's a short over a period of time, is it a consequence of the previously happened TBI? So that's all needs to be kept in mind depending on which lobe of brain is involved and what is the mechanism of injury. That's more important. Then coming to the pathophysiology, I know this diagram may seem to be a little scary, but I'll break it down for you. It's basically a schematic flowchart of the pathological changes which happen after TBI. I mean, starting from the acute to more chronic and neurovascular damage and the immune activation. So, immediately after traumatic brain injury, there is a neurovascular damage. Immediately after the insult, what happens is there is a large amount of DAMPs. What you call DAMPs is damage associated molecular patterns, and your PRRs, those are pattern recognition receptors. So these are actively produced in large amounts, and they are released, which cause gliosis and peripheral immune cell infiltration. So when I say these peripheral cell immune infiltration, the immune activation will happen. I'll show you the timelines and everything in a bit. So basically, when this gliosis and the peripheral immune cell infiltration happens, the initial function of these immune cells is to contain the injury and remove the existing debris and the dead cells. However, this unregulated immune response can cause enhanced inflammation and the injury progression. Further, it will cause a secondary injury like energy failure, oxidative stress, prolonged inflammation, excitotoxicity, glutamate being the most important excitotoxic agents. They lead to progressive injury with white matter damage and chronic behavioral deficits. So over a period of time, it can be from few minutes, hours to even years, this can progress. So this basically shows within few minutes what happens, hours, days, and weeks, and even months to years. So if you actually notice, there's a mechanical insult which leads to the acute neural injury. There's a blood-brain barrier damage, the glial injury within minutes, and it progresses to years. The necrotic and the apoptotic cell starts immediately after death, and it peaks within hours to days. The axonal shearing, that's the other important event which leads to demyelination and white matter injury. The neurodegeneration, traumatic encephalopathy, axonal injury, it can sustain for years, even after a single traumatic brain injury insult. So the acute insult and the neurovascular damage will lead to myeloid accumulation and recruitment of T cells, which can last chronic neurodegeneration and the which is responsible for the long-term side effects. So depending on the severity of the brain injury, the myeloid cells will recruit T cells and B cells. The T cells and B cells appear at the sites of brain pathology and later points in response, anywhere between 3 to 7 days post injury, and can persist about months. So, coming to the pathogenesis, how it is divided is primary brain injury and the secondary brain injury. Primary brain injury, it is the injury that occurs at the time of trauma, that resulting from various external mechanical forces which are transferred directly into the intracranial structures, which can cause bone fractures, contusions, hematomas, axonal injuries. Skull fractures per se may be inconsequential. However, the damage which cause underlying structures, the neurovascular, is the life-threatening injuries. It can result from the considerable contact force which is applied. It can be a closed fractures, depressed, non-depressed, L8, linear, various type of fractures. So depending on which part of skull is involved, the underlying structures, like a temporal bone fracture is there, there is a possibility of middle meningeal artery injury, which can cause a epidural hematomas. If there's a basilar fracture, there can be associated damage to the olfactory, facial, or auditory nerves. There can be a possible CSF rhinorrhea, otorrhea, which can act as a portal of infection, which leads to bacterial meningitis. It needs to be kept in mind before treating these TBIs with any of these fractures with CSF otorrhea, that this is a very, very important complication. And the open fractures itself, due to breach in the scalp barrier, that is prone for a lot of secondary infections. So the commonly implicated mechanism in these fractures or these road traffic accidents is the direct impact, the rapid acceleration and deceleration processes, the penetrating injuries, the shearing forces, which are very important in the diffuse axonal injury, which I'm going to discuss about in a minute, and the blast waves coming from the accidents itself. The primary pathophysiology would be the disruption of the blood-brain barrier, like I mentioned, and the loss of cerebral autoregulation, which is very important, which is in causing the cerebral edema, for the raise in ICPs, and also in the variation of the cerebral perfusion pressures. So morphologically, the primary brain injury is divided into cranial and intracranial. When you say cranial, we spoke about the skull fractures and the damage to the underlying neurovascular structures. Intracranial, again, it is divided into intraaxial and the extraaxial. This is just for us to understand. I mean, it's very important where it is involved morphologically, because our management can depend on that, and the specialist who should be involved depends on that. So the intraaxial injuries can be contusions, diffuse axial injury, intracerebral hemorrhages, and the extraaxial can be epidural, subdural, subarachnoid hemorrhage, and the intraventricular hemorrhages. So coming to the secondary brain injury. So secondary brain injury, the primary trauma will trigger a cascade of molecular mechanisms, like I mentioned in the previous slide, from within hours to days to years. So all these they all come under secondary brain injury. So what constitutes a secondary brain injury is the excitotoxicity, glutamate being the biggest culprit, the free oxygen radicals which are produced, the activation of these proteases, mainly the calpains, the dysregulation of cell cycle and the apoptotic pathways, mainly constituted by the caspases 3, 6, 9, 8, and 9, the disruption of blood-brain barrier, the inflammatory response, and the vasogenic edema which is produced, the loss of cellular autoregulation, that is raised in ICP, the changes in the cerebral perfusion pressures. Also, the stress response which the whole traumatic brain injury causes based on the event or the TBI itself, which causes the catecholamine surge and the subsequent secondary brain damage. So this is what I'm talking about, the primary injury, which is leading to the secondary injury, and subsequently the long-term neurological deficits, loss of neurological function, cognitive decline, psychological alterations, chronic disability. The cerebral perfusion pressure, what do we understand by it? The cerebral perfusion pressure is defined as a difference between the MAP and ICP. It's a clinically measurable determinant of adequacy of cerebral perfusion. It is regulated mainly by the cerebral autoregulation. And autoregulation is mainly a determinant of how the cerebrovascular resistance is. The normal range of CPP is anywhere between 50 to 100 millimeter of mercury. the traumatic brain injury will significantly affect the autoregulation. Hence, the cerebral blood flow and automatically the cerebral perfusion pressure will come to a very narrow limit. So, any change in the cerebral perfusion pressure can lead to increase or decrease in the cerebral blood flows, and depending will further worsen the ischemic brain injury. So, what are the factors affecting the cerebral perfusion pressure? According to the Brain Trauma Foundation, the guidelines, the CPP is recommended to maintain between 60 to and 70 millimeter of mercury in a TBI. The factors which which affect the MAP and ICP are the mass effect due to intracranial hemorrhage, the cytotoxic and the vasogenic edemas, the increase in resistance to cerebral venous blood flow, the acute hydrocephalus, the increased cerebral CVP, polytrauma with hemorrhagic shock, systemic inflammatory response, and the factors affecting the cerebral vascular tone, the partial pressure of the oxygen, carbon dioxide, and the ABG levels, the alkalosis. So here I want to discuss about Monroe-Kelly doctrine. This is actually it was recommended in 1700, 1783 or 1780 sometime by Monroe and Kelly. So basically what they've thought was brain is a very static thing, and we have a blood volume and a CSF volume, which is a dynamic thing. And the idea which they have proposed was about almost 200 years ago was there's a brain parenchyma, which is almost 80% volume, CSF 10%, and blood 10%. So if you see the diagram on the right side, basically what it essentially means is the compliance relationship between the intracranial contents is non-linear, and compliance worsens as volume of the intracranial contents increase. To put in simpler terms, the volume of intracranial contents is constant. If the addition of a mass such as a hematoma will result in squeezing out of equal volume of CSF or a blood volume. If you see the second and the third diagram, still it is within the normal limits, meaning it's still compensated. ICP is normal. The mass is there, there's a hematoma, CSF volume has reduced, the arterial volume or venous volume, not so much. In the subsequent, the decompensated state, if you notice, the mass is significantly increased. Brain volume is pretty much same. The venous volume has come down, CSF has significantly come down. All right. So this is what the Monroe-Kelly doctrine is. Interestingly, there is a Nature article in 2020 which discusses or provide an extension to this Monroe-Kelly doctrine almost after 200 years. I mean, there's a lot of studies which went on over the years, but this is a pretty interesting journal because they've mentioned actually, like we thought 200 years, that brain is not a very static thing. It could be a dynamic thing. That basically there will be a volume loss in the neurons. They become very lean when there is a severe traumatic brain injury. Mind you, it is only after reaching the decompensated level that initially brain is very very adaptable organ. It can sustain till it reaches the breaking point of severe traumatic brain injury. So in that state, this mechanism which essentially says that brain is static only in that state. Till then, brain is quite dynamic. So it's a pretty interesting research update. So we have several scoring systems. Please interrupt me at any point if you think I'm too fast or if there's any clarification you need. So severity scoring systems, there are few. The common one we use is the GCS. The other one is the 4-score, the Marshall CT classification, and the Rotterdam CT score. We use GCS mainly because it's very easy to use, very practical and simple, and very reproducible clinical tool. The maximum score is 15, the minimum score is 3. And based on GCS, like I've mentioned, we classify as mild, moderate, and severe. Any GCS between 13 to 15 is mild, 9 to 12 is moderate, severe is anywhere less than 8. Certain factors like intoxication, sedation, paralysis, and endotracheal intubation may limit the accuracy and the practical application. And you should also keep in mind it does not test brainstem reflexes. That's the downside of GCS. Coming to the 4-score. the full outline of unresponsiveness score. It includes the brainstem reflexes along with the eye response, the motor response, and the respiration. The minimum score is 0 and the maximum score is 16. It is fairly new and a comprehensive tool assess level of consciousness in TBI. One thing, the advantage over GCS is it does not affect by endotracheal intubation, unlike GCS. The Marshall score mainly it classifies into 6 categories based on 3 variables. I'm not going to go in detail into it. The 3 variables being the presence of the mass lesion, the appearance of perimesencephalic cisterns, the extent of the midline shift in the CT scans. It's also a descriptive and a prognostic tool. The Rotterdam scoring, again, it is also fairly new, about 2 decades, started in 2005. It uses the characteristics of basal cisterns, midline shift, the traumatic subarachnoid hemorrhage, the IVH, and the presence of absence of the epidural mass lesions. It's also for classification and the prognostication. And is a very reliable indicator. The Rotterdam score is for the 6 months mortality outcomes. It's a fairly accurate score. So coming to the intracranial pressure. So why intracranial pressure is such an important factor in managing TBI? We need to understand that the intracranial pressure normally is less than 50 millimeter of mercury in adults. However, intracranial hypotension, you need to understand persistent elevation above 20 is defined as ICH, intracranial hypertension. So an ICP target of less than 22 is recommended by the TBI guidelines. So a CPP cannot be reliably measured without measuring the ICP. So monitoring ICP continuously will enable us all clinicians to estimate the cerebral perfusion pressure and hence optimize the cerebral blood flow. If you have to increase the MAP, decrease the MAP, and subsequently the oxygenation as well. This helps us also to reduce the secondary brain injury, and there are various invasive and non-invasive techniques. So before we get into that, let us jump into the specific indications of uh, when we should monitor the ICP. According to the Brain Trauma Foundation guidelines, all salvageable patients with a severe TBI, like I mentioned, GCS less than 8, and an abnormal CT scan. When you say abnormal CT, I mean by hematoma, contusion, swelling, herniation, compressed basal cisterns. This is an absolute indication. The other absolute indication with the presence of severe TBI and normal CT is any of these 2 factors. Two or more. Age more than 40 years, unilateral or bilateral motor posturing, and systolic BP less than 90 millimeter of mercury. So these are the, I've mentioned the modalities, how we check ICPs. There is invasive and non-invasive. I'm going to come to non-invasive in a bit. Let us discuss about invasive. Just briefly, the first one is your EVD. We all know EVD. The advantage of EVD is it's fairly simple, accurate, and ability to drain CSF in order to reduce the ICP. The disadvantage being the risk of infection, bleeding, and the procedure itself. I mean, you need a trained personnel because there's a vascular compression due to hemorrhage or edema. The second thing is your epidural monitors. So epidural monitor, like you see in the picture, not sure if you can see my arrow, epidural bolt is basically it is a fiber optic transducer which passes through the skull bone and rests on the dura mater. It does not penetrate the dura mater, it rests on the dura mater. The advantage is the risk of hemorrhage and bleeding is less, infection is less. However, the disadvantage being the inaccuracy, as dura mater dampens the pressure changes in the parenchyma. The next one is your subarachnoid bolt. It basically goes through and through the dura. The advantage being the risk of, low risk of bleeding and infection again. The disadvantage being it can get blocked because of the debris. The last one is your interparenchymal monitors, which are becoming less and less common nowadays. What is becoming more common is the non-invasive techniques, and there are numerous studies which are done, and year after year the research literature is growing enormously on these 2 techniques. The transcranial Doppler, it basically measures the tributaries of the velocity in the tributaries of circle of Willis. the velocity in the cerebral circulation. It estimates the raised ICP by assessing changes in the blood flow velocities, and in response the resistance. The advantage is it is non-invasive, and the disadvantage is sometimes it can be inaccurate. So if the patient is restless, agitated, these can be inaccurate. The other one is your ONSD, the optic nerve sheath diameter. So basically, right side the ultrasound image, what you see is the globe, the eyelid. The back of it, the black portion, the vertical portion is your optic nerve. So what we are measuring is optic sheath. This 3 millimeter behind the globe, you mark a point and you mark the thickness. So up to 5 is considered as normal ICP. Anywhere beyond 5 thickness, you need to consider that beyond 5 or 6 millimeter, that ICP is raised. There are other techniques like optic tonometry, tissue resonance analysis, tympanic membrane displacement. They all lack accuracy and reproducibility. So they're not very common in clinical practice. So a quick question. I think any of the nurse practitioners from any hospital or our hospital can answer this. Can you identify the ICP waveform in the next slide? And you can go one step ahead and tell what are the other waveforms.
First one is arterial waveform.
The leftmost one. Very
The
good.
first one.
Very good, Vishwa. Okay, then the center one. The center one below. I'm sure you know that.
Yeah.
Yes, the center above.
ICP.
Want to think again? Okay. The center above is a JVP. The A, C, and the wave with the X descent and Y descent. Okay, it's a JVP. The right extreme, the P1, P2, P3 is the ICP waveform. Okay, thanks Vishwa for the volunteering. Okay, so we are going to discuss briefly about what these P1, P2, P3 stands for. P1 is your arterial pulse, P2 is your cerebral compliance, and P3 is your dicrotic notch. So P1 or your percussion wave, it just represents the arterial pulse which is transmitted through the choroid plexus. P2 is your tidal wave, which represent a reflection of the arterial pulse from cerebral tissues. And P3 is your dicrotic wave, which represent the dicrotic notch of the arterial pulse and is related to the closure of the aortic valve. Why it's important to understand P1, P2, 3 waveforms, their basic physiology and their changes in TBI is, it will tell us where the issue underlies. So depending on the waveform, we can interpret what is going on inside. So for therapeutic measure, to decrease ICP, the P1 amplitude remains same, while the P2 and P3 decrease in amplitude. So the intracranial pressure waveforms, they're quite dynamic and they show cyclical variation based on the arterial pulsations and your respiratory variation and based on your intracranial compliances. So when there is increase in mean ICP and the ICP waveform amplitude, possible conditions are the acute presenting of mass lesion, there is increase in CSF volume, severe arterial hypertension, hypercapnia, hypoxemia, decreased venous return. So these are all possibly reversible because the patient is intubated, ventilator is under control. We can change all these things, right? So it's very important to consider all these while monitoring. So this advanced monitoring, I'm not going to, these are all fancy terms. I'm not going to discuss any of these in detail. The only thing I want to mention is if you see the right side diagram, the number 1 and number 5 is commonly we do. Based on the driving pressure, we check the ICP, put an EVD, connect to the monitor and check. And the CNS function, we check the evoked potentials, the EEG, everything. So other things which is happening inside the brain, the cerebral blood flow, like I mentioned, the transcranial Doppler measures this cerebral blood flow. Then the oxygen delivery itself, that is where the jugular venous oximetry and the brain tissue oxygen tension monitoring comes. And the metabolism is monitored by the cerebral microdialysis. So depending on which part, the different techniques, but not lack of availability widely, that is why it hampers. So I'm going to spend next 5 minutes and talking briefly. I'm going to touch very briefly the management of TBI. It's very, very important how the patient is managed pre-hospital, at the triage and in the emergency and in the ICU. equally as important as managing the patient post discharge from the hospital. It's a very, very important thing that all these play a crucial role in improvement of the patient, including the nutrition and rehabilitation. So initial measures to reduce ICP would be elevation of head end to 30 to 45 degrees, which will adequately allow for the venous drainage. Also, if there's any neck ties, endotracheal tubes, try and loosen them so that the blood flow is adequate. It facilitates the venous drainage. Usually, analgesics, not analgesics, analgesics we give sedation mainly to ameliorate the sympathetic response. It also decreases the metabolic rate and provides ET tolerance. But however, the paralytics only use when there is a ventilator desynchrony. It is not commonly used because it can cause drop in blood pressures and cerebral perfusion pressures will decrease. So it's very important not to use so much of paralytics. Both hypercapnia and hypocapnia, like previously thought, is deleterious. So let us target normocapnia. That is what the brain trauma guidelines also mention, 35 to 40. And the osmotic therapeutic agents like mannitol and hypertonic saline. There are so many studies which debate both of them, but I think we can use both. But however, there are some theoretical advantages over mannitol in 3% NaCl because it can cause hypovolemia, uh, ongoing bleeding with less likelihood of leakage into the brain tissue. All these, there's a theoretical advantage over 3% NaCl, 3% NaCl over mannitol. So if you're considering mannitol, the dose would be 0.25 to 1 gram per kg. Can be given on 4 to 6 times a day. 3% NaCl, it can be used either 3% or 23.5%. 23.5% one is usually for intermittent boluses. The 3% one, we target or titrate the infusion to target 145 to 155 milliequivalent per liter sodium. So like I mentioned, there's no convincing evidence between 3% NaCl and mannitol. And yeah. And one more important thing which I would like to mention is try and avoid as much as possible to suddenly stop the mannitol or 3% NaCl because there is a possibility of rebound cerebral edema. That's an important factor which needs to be kept in mind. Then coming to your temperature. The therapeutic hypothermia has been proposed to cause raised ICP after severe traumatic brain injury. There's extensive trials which have done, the Polar trial in 2018. I mean, all these are shown to be deleterious and which has actually, in fact, instead of proving useful, they are actually harmful. So the prophylactic hypothermia and hyperthermia both are harmful. And there is also this concept of inducing barbiturate coma. This is only in severe traumatic brain injury to reduce ICP and to maintain the cerebral metabolic rate and to reduce the secondary brain injury. However, I mean, it is barbiturated coma is done because of by using phenobarbital infusion. However, it is not a useful practice because it can definitely used in the refractory intracranial hypertensions with stable hypodynamics, stable hemodynamics. If the patient is unstable, this would further decrease the cerebral perfusion pressures. So it's not very useful practice. The saline for resuscitation usually is normal saline is preferred for being hypotonic. And colloids are definitely contraindicated. Definitely albumin is not indicated in patients with traumatic brain injury. Hypertension should be promptly treated. Anti-epileptics, there is no particular choice of drug, but usually used one is phenytoin or phosphonatoin. Levipil is a fairly good alternative. A lot of people uh, uh, think that Levipil has the side effect of causing more altered sensorium and these things in TBI, but that may not essentially be true. But Levipil is also a fairly good alternative. Coming to the tranexamic acid, I mean, Crash 3 trial has proven that tranexamic acid given within 3 hours, 1 gram, is beneficial, and repeating it every 8th hourly, and has shown significant mortality benefit. Coming to the very controversial topic of steroids. So steroids need to be used, not used. It's an absolute no, because there is so many trials which have proven that it causes significant mortality over period of time. Even the 14-day mortality, 1 month mortality, and the 6 month mortality all prove that steroids worsen the traumatic brain injury. And neurosurgical intervention, definitely we know this. Only one thing I would like to mention is the DECRA trial and the rescue ICP trial. Both have shown that it will reduce the ICP and improve mortality, but it has not really shown to improve the neurological outcomes on a long run. So that is something which needs to be kept in mind. Definitely it reduces the ICP and the mortality benefit. I'm not going to discuss in detail about each of the procedures and the indications. I mean, that is fairly elaborate, probably out of scope of this discussion, because I'm just outline touching it. And so we come back to this patient. So our patient fairly underwent CT scan, and we have gone through all the management. So what is the outcome? So patient has significantly worsened. We've managed normocapnia, increased sedation. We've given 3% normanitol. We've further worsening. We've targeted briefly because there was herniation. We've targeted hypocapnia. We've tried barbiturate coma. We've tried decompressive craniectomy. That is one tangent. The other one is, suppose patient is improving. When do you have to titrate down? When do you have to dial down? There are specific indications. If the ICP, if the ICP is less than 22 for 3 consecutive days, less than 72 hours, I think we can stop the ICP monitoring and we can switch over to the non-invasive. That's very important to remember. And the next one is, how do you prognosticate these patients? Patients who are becoming sick. Like I mentioned, there are two: the impact prognostic model and the crash prognostic model. The crash prognostic model takes care of, it involves variables of age, which country the patient is from, GCS, pupillary reactivity, the presence of significant extracranial injury, and the specific CT findings. But it's just important to know the impact and the crash prognostic trials. So this is the most important thing. Prevention is definitely better than cure. So we all know that from reading Park and Park and community medicine textbook and going through COVID. So the key targets in TBI prevention would be the road traffic safety, the older people in high income states like above 65 years, the specific measures which are taken to prevent falls in these elderly patients. In children and adolescents, mainly because of road traffic accidents or sports injuries or whatever be it included in this children and adolescents. And the violence and crime is the third most common in globally for reason for TBI. And sports one I've mentioned. So this is a collective effort from WHO and CDC and all the partner nations. The global plan, this is 2021 to 2030, the decade of action for road safety, including India is partnered, and in all the highways there is a dedicated highway helpline to manage road traffic accidents. There's always an ambulance parked on highways and these golden quadrilaterals and all these. Lancet actually mentions, quotes what India is doing. It's an article in 2021. So basically the approach is what to do and how to do it and who to do it. These are essential or the involved parties. And the right part of the slide, which essentially mentions there's something called a STEADI, STEADI. It's mainly to prevent the accidents and falls in elderly patients and all the measures they should take. Almost NHS spends close to 450 million in addressing these. So this is what essentially the Lancet mentions, that we have to target for, don't have to go through the entire slide. It's not important, just the highlighted ones. Targets for prevention, which is identified, that is road traffic accident, elderly people falls. I mentioned all these. The ongoing prevention action, that is the 2021 to 2030 decade, then the CDC involvement, and each partner nation's involvement. And sports related injuries, there are so many protocols and guidelines kept in place. Even if any of you all watch football, if any football player has a head injury, they'll just stop the game for a few minutes till he's cleared. So it's very, very important. And the advances and challenges still remain, depending on which country we are talking about. There are a lot of favorable factors. Wide use of CT MRIs, triaging has improved, our diagnosis management skills have improved. A lot of skill development is happening, how to manage these patients, including in rural areas. However, there are a lot of unfavorable factors as well, because a lot of pre-hospital care, which is still lacking. There's a little evidence of, very little information of how the older patients are managed, and the resource constraints. I've discussed this both in the low economic and the high economic and the worldwide. And the future of research would be understanding about mild TBI. I mean, extensively I spoke about severe TBI. There is not much literature if you actually see on mild TBI. I mean, there are a lot of literature, but what can we essentially do? Because a small mild TBI, one incident can have a very lasting effect, cognitive decline, psychosocial issues over a period of time. So a good knowledge about mild TBI management and the literature, and better knowledge about managing these is very essential. And a lot of studies are in pipeline. Better classification, definitely GCS is not the best one. I think a better classification of how do we do it is, and definitely of future research on all these areas, including the managements. So if there's one take home message I would like to take, is this one slide. It basically mentions the BPSC factors, which which are individual differences which can substantially affect the outcome of the traumatic brain injury. That is your biological factors, which is brain injury severity, the host response, and the genetics of the patient, the origin of the patient basically. The psychosocial, the coping skills, the mental health, the social support and the employment, and the ecological, the healthcare systems which is surrounding the patient with the TBI. So all these play a significant role, including the nutrition and the rehabilitation. So I have not touched so much about the rehabilitation, but it is such an important factor. Even after putting so much effort into the patient, getting the patient out of hospital, it is very important to continue that for rehabilitation. That's the only way we can do justice for the patient. So thank you again, and wish you all a very happy Women's Day.
Thank you.
Any questions?
Thank you, Doctor.
I know it's a little lengthy talk, but I tried to summarize as much as I could. Any questions I can take?
Amit has a question.
Yes, Dr. Amit. Dr. Amit, I think you have to unmute. Okay. Anybody else? Any other questions? It is a fairly large topic.
Prudhvi, I mean, that
Yeah.
was very comprehensive and fantastic. Thank you very much, Prudhvi, for this month. Look, I had one question and one comment. The question is, I mean, yeah, not more so both are comments, I would say. You did mention in one of the slides that DECRA reduces mortality. Yes, it did reduce a lot of mortality, but the only problem is most people who were about to be dead just were alive. So it ended up the 6-month EGCS score, extended GCS score, was from dead to 5 or 4. Which essentially means that they were in persistent vegetative state for the rest of
I
the
agree
life.
with you. I agree with you.
So that is a unfortunate thing, but I also find that in India, people are okay with having the person alive more than the quality. I mean, because of a lot of many factors such as emotions play a huge
Absolutely,
role.
absolutely.
Thing.
And it bears significant burden on the healthcare. I mean, those are the patients, just one aspiration pneumonia, one small thing, and then burden on the system again.
Yeah. So not only healthcare, but as an individual, as a family, as a and as a closed unit, they are all essentially destroyed, I would say.
Yeah.
So my other comment is, I mean, it's more, I was just calculating one of your slides which mentioned about 8.2 million DALIs which are essentially affected, 8.1 million years lived with disability. That means if you take it into perspective for an individual, for myself as an individual walking on the streets or playing a game or in the street, I have almost 1 in 100 chances of in the world. In India, probably more.
All the more.
To do this. So that is that number actually hit me quite a lot. Thank you for this presentation, Prudhvi. Thank you very much.
Yeah. Yes, Sanat, it is difficult to let go, but I think it is definitely the knowledge and the awareness and a lot of other factors like Shashi was mentioning. But yeah, thank you all. Thank you all for your time.
Thank you.